Welcome to the Niagara Health System Difficult Airway Pathway Education Package. This is module number 3. This is a somewhat lengthy module, but I'm hoping that you will find it useful as this contains the key components of our difficult airway pathway that has been developed. On with module 3. As always, you can send your questions to shirastarfish@gmail.com or contact any of the members of the Difficult Airway Committee. So, as previously mentioned in the previous 2 modules, we had to figure out a pathway that was going to work for the unique needs of the Niagara Health System. One of the things that we mentioned in the previous 2 modules is that there is a number of algorithms in the literature, but those tend to be specifically designed for anesthesiologists in the operating room who sometimes have the option of waking the patient up. That's not always the case for us. However, there are some very key important themes and concepts that can be derived for any situation for any provider outside of the operating room. For us, we wanted to focus on our mission and vision, which was simple, sustainable, trainable, best evidence-based practice. And we wanted to make sure that we were going to give the opportunity for incorporating education and simulation training for everyone that's going to be using this pathway at Niagara Health. And that also meant a standardization of equipment and carts across all of the sites for simplicity. The key elements of this slide for our difficult airway pathway, first and foremost on the left-hand side, are mission, right people, right equipment, and right timing. And across the top, once a difficult airway is suspected or encountered, call for help. We're going to teach you how to figure out who, in fact, may be difficult. Call for help is extremely important. You're going to need assistance with skilled providers. And then the second component, the main piece, is our actual pathway, showing clearly laid out Plan A, Plan B, Plan C, and Plan D, with a focus being on a stepwise progression of steps with equipment and how to proceed. And we're going to focus on each aspect of this as the presentation continues. So let's focus on the first piece. Once a difficult airway is suspected or encountered, well, the very first question you should be asking yourself is, how do we actually figure out who might be difficult? As mentioned in a lot of the studies, an assessment and recognition of a difficult airway was something that was lacking across the board in all situations, across all disciplines. Well, early recognition involves airway assessment. And that involves the fact that every single patient should have an airway assessment. Why? Because we need to figure out who is going to be difficult. And difficulty isn't just with intubation. It also includes bag valve mask ventilation, how to insert or who might be difficult to insert a supraglottic airway device, and who may be difficult to actually obtain a surgical airway, which of course is really important because if these are your backup plans and those also look difficult, that might in fact change your entire strategy on how you approach this person's airway. So let's talk about some of those airway assessment things. First and foremost, a very rapid one. The first question you should ask yourself is the airway patent or is it obstructed? You can figure this out by looking for key vocal responses. Are they able to talk to you? If they're able to speak to you, their airway is patent and non-obstructed. If there's presence of stridor, that signals that there may be a problem at the level of the vocal cords. Ask yourself, is there a mechanism of injury for a trauma patient that may have presented, or what is their actual presentation to the emergency department? Why are they there? Shortness of breath, swelling, direct trauma to the neck. Ask yourself those questions. Then we go on for looking for potential triggers of a difficult airway, things that should give you a red light right off the bat. Body habitus. The morbidly obese patient is going to be difficult by definition. Thick neck, big tongue, tendency to obstruct, and tendency to desaturate. Restrictions. C-collar automatically makes it difficult for you to get a good view. Full stomach raises the bar in terms of a high likelihood of aspiration. And then simple things. Ask them to open their mouth. If they have prominent incisors and an overbite or a protracted jaw, that's going to mean that you're going to have difficulty getting the blade in and the tongue out of the way, making your view difficult. Their Mallampati score, their palate shape, and thyromental distance, things we're going to go over in more detail in the upcoming slides. And do they have a short, thick neck? That's going to make your ability to get a blade in and see things very difficult. Do they actually have an obstructing tumor or something compressing the airways, or is there actually debris such as blood obstructing your view? Those are all very, very important as they are going to make your visualization and ability to obtain an airway or do any of those other things very, very difficult. Airway assessment doesn't just involve the adequacy of the airway, but it also means their adequacy of breathing. This is also very important because this is going to tell you whether they're able to maintain their breathing pattern, and it can sometimes be an indication for you to intervene quickly. Adequacy of ventilation is the first thing we should be looking at. What is their respiratory drive? This comes from their brain. Things like intoxication and drugs will suppress that drive. Mechanics and work of breathing. Mechanics simply have to do with how well is the chest wall moving and the chest structures moving themselves. And work of breathing is how hard are they having to work in order to maintain their oxygen saturations. Is their respiratory rate 35 or is it 8 or 10 and look normal? Objective assessments of this adequacy of ventilation involve the things that we do all the time, their oxygen saturations, their respiratory rate, looking at how well that chest wall moves, and how well the air entry is equal to both sides. Other things is we can look for are tracheal deviations that may suggest a pneumothorax or a tumor, presence of subcutaneous emphysema suggesting that there may be a pneumothorax. Depth of respiration, or is it rapid and shallow, or is it a deep, regular respiration? Does it look paradoxical, meaning the chest wall is moving in an opposite direction to their abdomen, or are they using a lot of accessory muscles such as their intercostals, their neck muscles, and their abdomen in order to maintain their oxygen saturations? Level of consciousness and shock or hypothermia, of course, will all affect the drive and make it the breathing pattern difficult. Typical things that we look for having to immediately intervene for severe airway or breathing compromise are the two things we always think about. A need for protecting the airway, such as the unconscious patient who won't be able to protect themselves in terms of if they aspirate or vomit. Severe maxillofacial fractures in terms of lots of blood and debris and swelling that are going to impendingly obstruct the airway. Risk of aspiration from either blood or bleeding, vomit. Risk of obstruction from an impending neck hematoma, stridor because of ongoing swelling, laryngeal or tracheal injuries, or of course burns where the swelling and damage is being done directly to the vocal cords in the airway. And our ventilation standpoint or breathing component. Are they apneic? Is there a presence of neuromuscular paralysis? Are they unconscious and cannot adequately maintain their breathing pattern? Poor respiratory effort. These are those things we look at, such as rapid respiratory rates, high carbon dioxide, low oxygen, presence of cyanosis. All of those are impending respiratory arrest type situations where you're going to have to intubate earlier rather than later. And of course, severe closed head injury with a need for hyperventilation in our trauma patients, somebody who's imminently going to succumb to coning or swelling of the brain, we would want to intubate and hyperventilate in order to help prevent that from happening. So when we're going through this pattern and asking our questions about early recognition, there's really 4 key things that you need to consider. The first one is assess the likelihood of 4 key scenarios. Are they going to be tough to ventilate? Are they going to be difficult to intubate? And am I going to have a difficult time actually accessing the neck to do a surgical airway if all else fails? Second thing you need to ask are, what are my access points? How am I actually going to do this? Am I going to do this as a primary awake, or am I going to do a rapid sequence, or am I going to do something in between? Am I going to allow this patient to spontaneously ventilate while I secure the airway, or I'm going to make them apneic, or am I going to do something in between where they're sedated and don't fight? And am I going to do an endotracheal tube, or am I going to go directly to surgical airway as a primary approach? And then the last 2 things are extremely, extremely important. You must pick a primary approach and be prepared, and you must pick a backup approach and be prepared. This is how you are going to figure out what your access points and your plans are going to be in order to secure that airway in a rapid and safe manner. So here's some pictures of people that are potentially difficult. The gentleman on the far left with the beard and the scarring, that signals to you that he's likely had some sort of surgical intervention, which means your anatomy is going to be potentially difficult. The person in the middle is our large obese person who likely is going to be difficult in order for us to have a visualization, but also propensity to desaturate when we make the apneic. The gentleman on the far right has a full beard, and this makes it tough for us to be able to actually get a seal for pre-oxygenation, but often it hides a small chin, a receding chin, which makes our visualization very tough. They tend to have an anterior larynx. The bottom left, beware of tumors and things in the airway that you maybe aren't expecting. And then our last two are our trauma patients. So someone on the right with severe facial injury with a mandible fracture, you know things are going to be abnormal and swollen and debris and blood. And the guy in the middle is our inline stabilization, which makes our view difficult, also in the setting of having some debris and blood potentially in the airway. So what do we have available to you in terms of tools to make your life easier when you're going through these things to figure out who's going to be difficult? Well, the first thing is ask yourself, is there presence of any of the 4 Ds? Distortion, disproportion, dysmobility, and dentition. We'll go over those in detail in the upcoming slides. We have a mnemonic called BONES. This will help you figure out who's going to be difficult to bag, mask, ventilate. We have LEMON, which will predict who is likely to have a difficult laryngoscopy. We have RODS, which will predict who will be difficult to insert a supraglottic airway device, which of course is one of our backup maneuvers. And SHORT-DOA is who will be difficult to place an emergency surgical airway, which again, remember, this is our final common pathway when we can't intubate, can't ventilate. So we need to be able to do this to figure out the likelihood of any of these scenarios. And we're going to go through these in detail in the upcoming slides. With respect to our surgical airway, there's a couple of really key things that are important that you should ask yourself. First of all, if they had any previous surgery or radiation to the head, neck, or jaw, that's going to make contracture, scar tissue in your anatomy not to be what you think it is. Presence of expanding hematomas or tumor are going to make it impossible for you to landmark, and obesity is going to make it tough for you to landmark. You may actually have to change your technique. The presence of trauma and C-collar will make it difficult for you to access the front of the neck. So those are some quick and dirty things that you can keep in the back of your mind outside of the mnemonic that are going to be fairly obvious to you when you stop and think about it, why that's potentially going to be difficult. So let's go on to the 4 Ds. So disruption or distortion of the anatomy, things that are going to cause your larynx and your vocal cords and your neck to not be in the anatomical relationships that you think. So for example, a hanging or a crush injury directly to the neck is going to obliterate your normal anatomy and make it very, very difficult. Those types of patients are somebody that you should think very carefully about your approach and maybe do an awake fiber optic as your primary approach. Penetrating trauma or other soft tissue injuries to the neck, such as burns or lacerations to the front areas of the neck, are going to potentially cause distortion, swelling, and bleeding in the area, also making it really difficult, and pushing your key structures out of the way, making it really very tough for you to figure out what you're looking at. And this happens even more importantly if you paralyze the patient, because that normal architecture and tone of the muscles that are hanging on and keeping those things in a normal place will now be completely obliterated. Dysmotility of the neck. In order for you to actually be able to get a decent view, the neck has to be able to extend. Well, if you're an elderly person and have lots of arthritis, it's going to make it impossible for things to extend. And if you have a neck collar on and C-spine immobilization, you can't really extend the neck, so that automatically makes your ability to intubate difficult. Dentition, full versus dentures or dislodged. Beware the edentulous elderly patient, because they typically have bad arthritis. The one saving grace is there's a little bit more room for your blade, but typically their neck isn't going to extend. If they have a full set of teeth, it also narrows your ability to get a blade in. And if teeth have been dislodged, then that's a signal to you there's actually been significant force and trauma, and potentially there may be anatomical structures that have been actually disrupted. What about our bag valve mask assessment? Well, we use the mnemonic BONES. And BONES basically stands for beard. Do they have the presence of a beard? It's going to make it impossible for you to get an adequate mask seal. If you can't get an adequate mask seal, you're not going to be able to pre-oxygenate, and you're not going to be able to bag them effectively. If they are obese, there's going to be lots of obstruction from the soft tissue. So their tongue's going to get in the way, the back of the oropharynx is going to be fairly full, And even when you do get a seal, you're going to have to generate extremely high pressures in order to actually raise the chest. And the tendency then is you're going to overdistend the stomach. No teeth. They have flaccid skin. They're losing that supporting structure that are supplied by the teeth and the jaw. So essentially, you're going to have these big gaps on the side of the mask and you can't get a seal. You're going to end up having to kind of scoop them up and use an oral airway in order to try to get some sort of a seal. From our elderly population, poor muscular tone, edentulous, poor C-spine mobility, all of those things make it difficult for you to get a proper seal and effectively bag malvast the patient. If there's a presence or you hear a history of that the patient snores, means they likely have obstructive sleep apnea. What does that mean? Well, it means when you lay them flat on their back, they're going to obstruct the baseline, which means when you go ahead and you paralyze them or they become apneic, it's going to make it even worse, and it's going to be very difficult for you to override that in order to be able to bag the patient. It means they're very prone to rapid desaturations and hypoxemia, even with the smallest interruptions of oxygenation. And severe facial injuries, that's somewhat obvious, but if there's facial burns, angioedema, trauma swelling from an abscess or infection, it's going to make it really tough for you to get a seal, and it's also going to make there a tendency for things to obstruct. So you're not going to be able to overpressure that when you're trying to bag the patient because it's a fixed obstruction. The unstable midface or mandible fractures become really difficult because you actually lose all of the supporting bone and muscle tone, which means the whole midface actually falls to the back of the oropharynx and causes obstruction. So those patients can be very, very difficult in order for you to bag them because you can't get around this fixed obstruction. What about difficult laryngoscopy or intubation? What do we have for us? Well, the mnemonic is lemons. First thing is you want to look externally. Do they look immobilized with a C-spine collar? Do they have a small chin, an overbite? That's going to mean that you're going to have an anterior larynx. Is there swelling or bleeding present? That means you're going to have debris in the way. Are they obese? It's going to make it tough for you to visualize anything. Do they have large breasts? They're going to flop and be in your way when you're trying to put the blade in. That's why we have that short, stubby handle. They have a short, thick neck. Also very difficult for you to get around that with a standard blade. Well, we also use this evaluate 332. We're going to talk about that in the next slide, but essentially what it does is it tells you how difficult is it going to be for you to actually place your blade and get mobilization to see. We look for the Mallampati score. We'll also review that on the next slides, but essentially you're looking for how much of your vocal cords in the back of the hard palate, the back of the oropharynx, and if you have poor Mallampati scores, you're really not going to be able to get much of a view. Neck mobility, again, we talked about this. If you can't move the neck, you're not going to be able to align the axes, which I'll speak about in the next slides, which also means you're not going to be able to find the cords. Is there presence of obstruction? We talked about that. Things in the way, you can't see. Scene and situation. Why are they needing intubation? What are those indications that we talked about? That's going to help tell you a little bit about what you might be in store for. And then medical history. So things like diabetes, acromegaly, thyroid dysfunction, all of those affect soft tissues, make them stiff, make it difficult for things to move. So it's really hard to compress those structures and move them out of the way with the blade. Pregnancy, same thing, but the difference there is they have friable tissues. So just touching them from the progesterone load actually makes them bleed. And of course, our autoimmune and joint diseases and degenerative things, again, make everything stiff. And all of those things can also increase your risk of aspiration. So let's talk about the 332 rule. This is what we use in order to predict difficult laryngoscopy. So first slide on the bottom, you see A. I want to see with mouth opening, can I get 3 of my fingers in there? If I can, then I should be able to fit a standard laryngoscope blade in and probably be able to get a glide scope blade in. Everyone defaults to glide scope. It's a good thing. But if you'll notice, the profile of that is actually a little bit bigger. So you need to be able to get that into the mouth. Number B, which is the middle picture, we actually look at the angle of the jaw to the chin, and we want to be able to get 3 of our fingers in there because that's going to tell us how easy it's going to be able to lift that tongue forward and up and out of the way. And if you can't, number C is top of the thyroid cartilage to the bottom of the jaw, which should be more than 2 fingers. And if you can't do that, then that means that even if we're able to get the blade in and move the tongue out of the way, the larynx is going to be very anterior, which is difficult for us to actually visualize once we're able to do all of that. Any single indicator is really poor specificity on its own, but if you put all three of those things together and you say have 2 out of the 3 that aren't very good, then chances are you're going to have a really tough time visualizing anything when you, in fact, get your blade in place. We talked about Mallampati. That's something you can do. This is how easy it's going to be to see vocal cords. And again, they range from class 1 on the far left all the way over to class 4 on the right with increasing difficulty. So if I have a grade 1 view or class 1 view, I'm going to be able to see 99% of the time I'm going to be able to a grade 1 view of the cords. If I have a grade 4 when I ask them to open up their mouth, there's a 99% chance that I'm not going to be able to see much of anything with the cords. And so this tells you basically how easy is it and how successful am I likely to be. Pretty good on the left-hand side with 1s and 2s, and pretty awful on the right-hand side with the 3s and 4s. This slide actually talks about neck mobility and the measurement of the atlanto-occipital angle. And I think this is important and maybe will help you understand what it is that you're actually trying to achieve when you put the patient in the sniffing position and you extend their neck. So in component A on the right-hand side, you see that we have 3 competing axes. We have a straight up and down horizontal oral axis, we have a pharyngeal axis, and a laryngeal axis. And when someone's sitting there with their mouth open flat, there is no way that those 3 things are aligned. In B, when we actually put them into a bit of a sniffing position, you can see that our pharyngeal and laryngeal axes actually line up pretty well. But where we have a problem is that we're at a 90-degree angle to the oral axis, which is where the blade is going to go in. So in order to bring those more in a line, we actually extend the neck, and you can see in C, we bring all of those closely together. And as you notice, the angle that you achieve there, which is about 30 degrees, is very similar to the shape of your laryngoscope blade. That's the whole point, is to align all 3 of those axes. Well, one of the things that you can do is you can actually measure the atlanto-occipital angle, which is shown in the picture on the left-hand side. And especially what you're actually doing here is you're trying to figure out how easy it's going to be to align those 3 axes. So what we're trying to do here is estimate that angle. You have the occluded teeth at the surface, and you draw a line, and you go to the just below the ear, and then a straight line across at the jaw. And essentially, this is going to help you decide who's are you going to likely have a good view with. If you have more than a 35-degree angle, the likelihood of you having a grade 1 view and easy intubation is quite good. If you have a grade 2, if you have a smaller angle, 22 to 34, it's a grade 2 view, so still not too bad. But if you get below 20 degrees and lower, this is where you get into the grade 3 and 4 angle, which is going to make it really tough for you to be able to see the vocal cords, even if you're able to get that blade in. Again, because we can't align that oral axis with the other 2 axes in order to be able to see anything. What about obstruction? We talked about that. Difficult laryngoscopy and intubation, if there's a presence of obstruction, is going to make it difficult for you to find your anatomy and your vocal cords. Things that get in the way, we talked about blood, vomit. Teeth can get in the way in terms of if they have dislodged, or if you have an overbite and some of those things making it difficult for you to actually get your blade in. Dentures can fall and get into the way. Epiglottitis, epiglottis can get in the way if it's swollen and inflamed, or if it's big and floppy. Tumors, of course, can cause obstruction, or you can have funny things like foreign bodies and piercings, which you aren't exactly looking for, but can fall into the airway, particularly once the patient is paralyzed, and cause obstruction. All right, what about difficult supraglottic airway device insertion? Our mnemonic is RODS, and that stands for restricted mouth opening. If you can't get the mouth open, you will not be able to fit some of these devices in, and you'll notice how large those are when you have your opportunity to practice in the sim lab, but you need to have a bit of space in order to be able to fit that in. Obesity or obstruction, again, just like bag valve mask ventilation, essentially you have to be able to get a seal, and if you have any type of obstruction from things that are in the way, or you're obese, we are going to overpressure that device, and you're basically going to get a leak, or you won't get it to sit and seal properly in the back of the oropharynx, causing basically no way to ventilate the patient. Distorted or disrupted anatomy, for exactly the same reasons, you need to be able to have that sit in the back of the oropharynx and seat properly. If you have those things present, distortion or disruption, it will not sit properly and you won't get a seal. Stiff lungs, you'll overpressure the device, you'll overwhelm the seal, you won't be able to ventilate or oxygenate your patient. And back to the final thing that we talked about, which is our difficult surgical airway access. That's our mnemonic short DOA. Surgery, presence of previous head, neck, tracheostomy tubes, scarring, those types of things are going to distort your normal anatomy, make it difficult for you to actually landmark. Hematoma or infection presence, again, causing distortion and movement of the anatomy, making it difficult for you to find things. Obesity, again, short, fat, thick neck, you're not going to be able to palpate your landmarks. Radiation, if they've had previous radiation to the neck, they're going to have completely stiff and scarred soft tissue and traction on the structures, and that's going to cause the anatomy to be distorted. And again, things are not going to be where you think they are. Tumor, again, pushing things out of the way, distorting the normal anatomy. And of course, direct neck trauma is something that we worry about. If you have crush injuries or hanging or any of those types of things, the normal anatomy will be disrupted. Obstruction from a foreign body will make things difficult, again, pushing things out of the way. And access, if they've got a full beard that extends down, or a collar, or a flexion deformity, or a halo vest, or a short neck, you're not going to be able to get to their trachea or cricothyroid membrane in order to do anything. All right, so what happens if you go through all of these mnemonics, you do all of your airway assessment, and this is what happens to you. You realize, holy cow, this is going to be really tough. I'm going to need some help. And that's the first thing you need to recognize is you need to call for help. Misery loves company. You need skilled providers. So who do you call? Well, in our algorithm, we stress that you call for help. And for us, at our site, we have a number of people that you can call within the Niagara Health System. Depending on the site that you're located, you're going to pick the person that's most readily available. First and foremost, call another colleague, someone else to help you that's readily available. A respiratory therapist, they're all going to be trained in this. Anesthesia provider who may be able to come and give you a hand. A ear, nose, and throat consultant, the intensivist, or the general surgeon. Who you call depends on what site you're at, what you're dealing with, your skill level, and what your airway assessment leads to in order for you to do your primary and secondary plans. That's going to determine who it is that you involve and at what point. Okay, so let's go through our actual algorithm. Let's focus on Plan A. Plan A's whole purpose is to actually try and make your first attempt the best attempt. We want to get that endotracheal tube in on the first attempt, and Plan A involves bag valve mask ventilation and tracheal intubation. And your primary approach can be either direct laryngoscopy or video laryngoscopy, depending on what your assessment tells you, as well as what your actual skill level is. We have key elements of Plan A that must be followed. The first and foremost priority is you must maintain oxygenation of the patient. And how do we do that? We want to optimize our first attempt. And how do we do that? Well, we pre-oxygenate our patient, we position them appropriately in a head-up sniffing position, and we use muscle relaxants on the first attempt unless there is a direct contraindication to doing that, or your airway assessment tells you you're not going to do that. Use of video laryngoscopy for less skilled providers or a potentially difficult person has been well recognized in the literature. Go ahead, have that available to you. Make sure you also have a bougie and an alternate blade available for you. And those are included in your attempts. Consider apneic nasal oxygenation in your high-risk patients, and that's our Airway that we have available at our site. And I will speak on the next slide about pre-oxygenation and positioning in a little bit more detail. Cricoid pressure, if you're using it for a rapid sequence, should be removed if difficulty in intubating is encountered. And there is an absolute hard and fast rule here, maximum of 3 attempts in 2 minutes. If you are unsuccessful, you must declare that you have a failed intubation and move on to Plan B. So let's talk about pre-oxygenation and maintenance of oxygenation. Well, this is really critical. We talked about this. We want to use, in our high-risk patients, we can use Airway. This is a passive high-flow oxygenation cannulas. And later in the pathway, there's continued attempts at oxygenation, both passively and actively, through either bag valve masking, the supraglottic airway device, or passive. And you can see a couple of different oxygen delivery devices in the 2 slides in the middle. So the first one you see passive flow by nasal cannulas and use of a bag valve mask, And then you also see in the bottom, that's a high flow oxygen mask that's being used to deliver oxygen, as well as some nasal cannulas underneath that. And on the left-hand side, that's in the operating room. However, you see that they've got them in a head-up position at approximately 30 degrees, and this favors proper oxygenation and filling of the functional reserve capacity of the lungs, making it giving you a longer apneic time before they start to desaturate. So this is really, really important that you maintain oxygenation at all components in the pathway. All right, so you're unsuccessful. You've declared that you cannot intubate the patient. You move on to Plan B. Plan B's focus is maintaining oxygenation, and we're going to try to do that by inserting a supraglottic airway device. And we use second generation devices. We'll explain those to you, and you'll have an opportunity to see them in the sim lab. And if we're actually successful, then we need to really stop and think, because we weren't able to get the tube in. So now we're oxygenating the patient well. We need to figure out, do we actually need a definitive airway right away? And if we do, then we need to figure out how we're going to secure that airway. We can intubate via the supraglottic airway device. We can do a fiber optic intubation. We can call someone else to help us. Or we can, if we think it was a major problem and we're not going to get anything from the top end, we could move directly onto cricothyrotomy or tracheostomy. So what is the priorities of Plan B? Well, the priority is, again, maintaining oxygenation of the patient via the supraglottic airway device. Again, paramount. We need to get oxygen to our patient at all components in this pathway. So if we're using an RSI and we haven't been able to get it in, and you're going to place a supraglottic airway device, you need to release that cricoid pressure in order to get that supraglottic airway device into the back of the oropharynx and allow it to seal and sit properly. We want to continue passive oxygenation like we talked about through the nasal cannulas, whether regular ones or high flow. And again, maximum of 3 attempts with that supraglottic airway device in 2 minutes. If you cannot get that supraglottic airway device in and you cannot oxygenate your patient, you must declare that you have a failed supraglottic airway device ventilation and prepare to move on to Plan C. We are not recommending blind intubation through the supraglottic airway device. We are recommending that you either use a bronchoscope-driven intubation technique, or that you use a fast track LMA. And again, that's a specific type of LMA that will be included in our difficult airway cart. You'll be able to review those and play with those in the sim lab. We're now going to move on to the key elements of Plan C. Plan C is our final attempt at oxygenation and ventilation of the patient. We've moved through A and B. We are still having difficulty getting oxygen in the patient, and this is our final attempt that also involves paralysis of the patient. Essentially, we have some key elements of Plan C. It's our final attempt to oxygenate via bag valve mask ventilation, and this is using a two-person technique, so someone that's going to be holding the face mask using an oral airway to get a good seal, and a second person that's actually going to be squeezing the bag in an attempt to try to get a good seal, and the last attempt at getting chest rise and oxygenation. If we're unable to bag valve mask the patient at this point, we're going to actually advocate that you go ahead and paralyze the patient, even if you haven't done so already. And the main reason, although this is counterintuitive, is that the level of obstruction may in fact be at the vocal cords. They may be in fulminant laryngospasm, and that may be the reason why you're not able to actually get oxygen into this patient. If you're able to successfully bag valve the patient, either at this stage or with the use of paralysis, this is a really important juncture. You need to stop and think. And we go back to that box on the right-hand side where we're specifically asking ourselves, do we need a definitive airway immediately? And if we do, we need to be thinking about how we're going to do that. We can intubate again through a supraglottic airway device. We can do an awake fiber optic, get some help, or move primarily onto a surgical airway. If you are unsuccessful, you must declare it cannot intubate, cannot oxygenate the patient. This is super critical. This means you need to be moving on, getting ENT, Gen Surg, ICU ready to go, because you're now in the critical stages where you're going to have to move in to a surgical airway. And remember, we've gone through about 4 minutes of time at this point, and that's 4 minutes where we haven't been able to get oxygen into this patient. We have to start preparing for Plan D, and while we're doing that, we're going to continue to attempt to oxygenate the patient through face mask, a supraglottic airway device if it's in and we're getting partial, and the nasal cannula. So So Plan D focuses on rescue front of neck access, and we're going to be advocating a specific type of cricothyrotomy using a scalpel bougie endotracheal tube. This is something that will be discussed in the Module 4. But the key elements of Plan D is that if you have not already called for help, this is a point in time where you absolutely need to do so. We need you to continue to attempt at oxygenating the patient using a face mask, further attempts at supraglottic airway device, either insertion or oxygenation, while you're preparing for the emergency front of neck access. And the surgical technique that we're going to advocate and teach all of you is something called scalpel bougie endotracheal tube. And again, we'll teach you in Module 4, but the reason that we're doing that is that this is going to allow us to maintain normal minute ventilation with a standard breathing system and a standard endotracheal tube. It allows a much better outcome, which we'll go over in the upcoming slides. But we also want to remind you that a high pressure oxygenation via a narrow bore cannula, what we used to use for jet ventilation, really is not advocated anymore in adults. Something totally different for pediatrics, that is something that's advocated, and we'll go over that in upcoming modules. Once you've obtained the airway using this technique, you must consult ear, nose, and throat, and you must send the patient to the intensive care unit. So in summary, our Niagara Health difficult airway pathway brings in key features and elements from the available literature, using techniques and concepts that are well established in the anesthesia, emergency medicine, and critical care literature. One of the key things is you must do an airway assessment on all of your patients, and this includes not only their ability to be intubated, but also bag valve mask ventilation, supraglottic airway device insertion, or the ability to obtain a surgical airway. And you need to do all of those things that you can fix a primary and a secondary approach in order to be successful. If your airway assessment leads to any types of concerns with difficulty in any of those aspects, you should call for help. And then when you are moving down our pathway, Plan A, make your first attempt best attempt with focuses on pre-oxygenation, continued oxygenation of the patient, video laryngoscopy or direct laryngoscopy. If you fail, then you must declare a failed intubation, move on to Plan B, which focuses on oxygenating the patient through the insertion of a supraglottic airway device while passive oxygenation is maintained through nasocation. So Plan C is our final attempt at bagging the patient using a two-person technique, an oral airway, with the addition of paralysis if we haven't been able to get oxygen into the patient in case the level of obstruction is at the vocal cords. If we can't get oxygen into the patient, we declare a cannot intubate, cannot oxygenate situation. This is a true emergency. This is a dire situation. We're going to immediately move on to Plan D while we're still trying to get oxygen into the patient. Plan D is our rescue front of neck access, which is us preparing for an emergency surgical airway using a scalpel bougie endotracheal tube technique for our adult population, which we're going to teach you in Module 4. And this is all being done while there's continued attempts at oxygenation. Well, I hope that gives you a summary of our pathway, and we will move on to Module 4, where we will go into more detail about our rescue front of neck access and our emergency surgical airway techniques of scalpel bougie endotracheal tube.